Welcome back to Inside ISAPN, your source for all things APRN in Illinois. I'm your host, April Odom, family nurse practitioner and the current president of ISAPN. In today's episode from our From Clinician to Leader series, we're shining a spotlight on the clinical nurse specialist role and the leaders who are advancing it across Illinois. And today I have the pleasure of being joined by Cheryl Herrmann, cardiac clinical nurse specialist, longtime ISAPN member, and our current CNS specialty representative. With over 20 years of service to the organization and a clinical background that spans critical care, cardiology, and even labor and delivery, Cheryl brings a unique and passionate perspective on advocacy, professional growth, and what it means to elevate the CNS role in Illinois. Thank you so much for being with me today, Cheryl.
You're welcome. It's great to be here.
Thanks. So we'll get right into it. If you can just tell us a little bit about your career path as a clinical nurse specialist, especially highlighting on your work in your three areas that you mentioned, that we mentioned briefly.
Yeah. Well, just to start out with my career, it's been a wonderful career. And I always tell people, I hope that you enjoy nursing as much as I did. I've always loved being a nurse. Now, there's sometimes I didn't necessarily care for my job, but I always have loved being a nurse and with that. And I always think it's just really ironic because my mother says she has no idea why I decided to be a nurse. But I have a book that I have saved that in first grade, our teacher made us write all these different things, cut out pictures. And I cut out that I wanted to be a nurse. And she wrote 1981. And you know what? That was the year that I graduated because she figured it was a diploma. And it's like, wow. Okay. So fast forward, I get into high school and I'm planning to be a nurse. And, I was going to go to in Peoria Methodist because there were just a couple choices. And so we took our ACT test and I hadn't taken physics or chemistry, a lot of those classes. And I did not do well on my ACT. And we had a counselor that came from a college and said, "You're not smart enough to be a nurse." I was devastated. But my high school counselor said, "You're one of the few people that have come through this high school that said from day one you wanted to be a nurse and you still want to be a nurse. You will be a good nurse." Now, mind you, I was salutatorian of the class, so I don't know. But anyway, I just think that's ironic. And I say that because you know what? Everybody can do things, as they do. So I went on, got my diploma degree. So with that, and I started working in a CVICU night shift. Well, actually, it was an SICU. We switched to a CVICU, neuro ICU, and just thoroughly loved that job. I enjoyed all my jobs, but I think just that one was the most favorite. I worked there 15 years as a bedside nurse and mostly with cardiac surgery patients. So as far as like in my bachelor's degree, the reason I went for my bachelor's degree is I'm one of these, my philosophy in life has been seize the opportunities before the opportunities present. I had heard that at a conference. Okay, so our hospital said, you know what, we want people to get their bachelor's degree. So we're going to bring the instructors to the hospital and pay for them. So why not?
Right.
Why not? Okay. And people like, "Why are you doing that?" And I said, well, because I was in my early 20s. I said, because when I'm 50, I don't want somebody to tell me I need to have my bachelor's degree. Mm-hmm. So I plugged away, and then a lot of people dropped out. So they ended up not bringing the classes there, but they still paid for it. And I took a class every semester, and it took me 10 years. And the other people were like, "Wow, how'd you get that done?" And I said, well, just slowly and slowly. And I will say that some of my friends that chose not to do that when they were 50 had leadership positions and went back to school. I didn't say no, but, right. But it was just ironic because I had said that at 50, I don't want somebody to tell me I need to go back to school. And that's when they needed to. So anyway, as far as I love my job as a bedside nurse. So I really was kind of like, what do I do next or whatever. And when I finished my bachelor's degree, the last few years, there were a few of us that were together as nurses. And so they had decided they were going on for their master's degree. And I remember standing at the elevator, they gave me the GRE book and they said, here, you're going with us. I said, I am. They go, yes, you are. I said, okay. So I started in a master's program. And at that time in the Peoria area, we had family nurse practitioner, clinical nurse specialist, or a nurse leader. Talking over with different people. I knew nurse leader wasn't quite what I needed to be because I was so heavy bedside, and clinical. And I really didn't want the family nurse practitioner. Probably at that time, acute care nurse practitioner would have been a great role for me, but it wasn't in our area and there really weren't many in that. So I chose the clinical nurse specialist role, and I am really happy that I did. And so I went through that and went through the thing, and people are like, what are you going to do when you get done? I said, I don't know, we'll see what happens. Well, with the hospital, they were forming a heart care center, and so they did create a clinical nurse specialist role for me. So
Okay,
that
great.
was really exciting.
Mhm.
And the one thing that I like about the clinical nurse specialist role is there's 4 different aspects of it. You can be like a clinical expert, you can have a research component, investigator, you can be a consultant, or also educator.
Hmm.
So it's all those in there. So it's really, when I think of the clinical nurse specialist, is looking at the whole population of patients and being the clinical expert for that, versus more like the educator may not be looking at all the population, but actually doing education, which is very needed. Not
Mhm.
planning that, but to put that clinical expertise with that. And so some of the things that I've been able to do with that clinical nurse specialist, we did develop a heart care model at that time and did a lot of education with the nurses, because I said, if we're going to have an expert cardiac care, nurses need education.
Mhm.
and so, and that, held for about 20 years. So not as much since after COVID, but I just had a whole curriculum that I felt like nurses needed to know. And I am humbled, but I do have people that have gone on to other jobs and they say, you gave me the foundation I needed
That's
to
great.
jump start. So that always has been good, and had one that just came back to work with us. So
Oh,
with that, so I didn't know if you had anything to interject, but I could talk a little bit about projects.
yeah, no, that's really great to hear, just like that experience and how you were, developing this education and for the future is like the biggest thing that most people I've talked about is like just how nurses, our past nurses have created this foundation for us, which we need, and we have to do it for the next generation.
Yeah.
So yeah, so like maybe share something. I know you talked about like cardiac, but you also were in labor and delivery too. Was that a short stint or was that a little bit of time or
Well, it was just a little bit. And, if you really look at my resume, I do get the 7-year itch. Okay. And it was 7 years after I'd been critical care nurse. And so I thought, well, I'm going to try labor and delivery, which I did really like labor and delivery. It was fun and it was a very, very good experience. But the one thing that I really didn't like about it is I worked night shift, and you may have only had one patient, or I mean, it could be slow at night. Then all of a sudden, all the ones that were having C-sections in the morning would come about 6 o'clock in the morning. And I'm like, I'm ready to go to bed, not work hard.
right?
It was just hard for me to adjust to that. But I
Yeah.
did like it. So I missed critical care. So I went back to critical care. And ironic, the OB department and the cardiac unit were on opposite ends of the hallway. So
Oh,
everything was on the 5th floor. And so then fast forward about 4 years later, just I call them medical politics, and I don't know, all you know what happened. But anyway, with health insurance and things like that, going to PPOs, um, we ended up having 90 extra nurses than what we needed
Wow.
with the patients. So, which meant they didn't want to lay people off. And so they were going to, we had to take our vacation time or not get paid.
Mm.
Well, I talked to my friends in labor and delivery. They were still really busy. So I started working PRN in labor and delivery
Mm.
again because I had that skill. And I mean,
Mhm.
it was good because I was still getting paid. Nobody had to take their vacation time.
Right.
I mean, it just really worked well.
Worked out.
And then when we kind of right sized, they still needed help. So I always said I would work my 8 hours because I was an 8 hour night shift person. Then at 7 in the morning, I'd come over and I'd help with the C-section. And then I'd recover the mom that had her C-section, and then I would go home.
Oh,
So I worked in critical care. Sometimes they'd die. Then I'd go to labor and delivery and bring a
oh,
new life in. So
oh,
that was kind
wow.
of on the same end. So I just kind of a little bit joke about that, but it was true. Not every night,
Mhm.
but
Yeah.
it was.
And
So
it's just so that's the one thing that I love about nursing is the diverse, like we can do so many different things.
things.
It's like, you can do labor and delivery, you can do critical care, you can be on this end and that end. Like it's
Yeah, yeah. And, and as a cardiac clinical nurse specialist, I delivered a baby in the
right.
hallway
Oh
because
wow.
I heard I was to go into the copy machine and I heard this, um, the the baby's coming. And I thought that sounds closer to the cardiac unit than the labor and delivery unit. So I thought maybe I better turn around and help. And I
Oh
did,
wow.
and I helped catch the baby.
Oh.
And we were still outside of labor and delivery, and there were other family, not hers, sitting out there. And I just distinctly gave them verbal instructions. I said, run into the labor and delivery and tell them we delivered a baby here. We need help.
They'll come running.
They came a running. I was
Yes.
just like, go tell them we need some help. That the
Wow.
baby did fine and
That's great.
everything else. And so I did that. So that
That's
was
great.
just kind of fun. But cardiac was mine. But now I do have a special interest in women and heart disease. And so there is a whole thing here, which if you're going to attend the ISAPN conference, there will be a recorded session on women and heart disease. And with that, they are finding out adverse pregnancy outcomes predict cardiovascular risk factors
Mm.
for later in life. So if
Mm.
you have preeclampsia, you have a better chance, not a better chance,
Better.
a higher risk
Iris.
of having cardiovascular disease later in life.
Oh
So
wow.
it's just a fascinating field in
Mhm.
that. And when I talk a little bit about that, my research, so that's another aspect of CNS, my thesis was on looking at what kept our cardiac surgery patients in the hospital longer.
Mm.
And so our female patients stayed 3 days longer than our male patients.
Hmm.
Now, I graduated back in 96, so we're going back a little bit.
Mm.
And of course, you have to explain why that happens. At that time, there are only 2 or 3 articles on women and heart disease.
Mm.
And they were saying women have different symptoms than men. And
Mhm.
so we started, I looked into that. And as we were doing our heart care center, I said, hey, women have different symptoms. And we started doing advertisement on that. So that
Oh.
was how my research project was able to help the hospital. And I've had that interest in that now. And like I said, going to still talk
Okay.
about it at ISAPN conference and
Yeah.
got another one coming up. So
Perfect. That's really great.
yeah,
Okay.
so that's the research expert of it. Yeah.
Mhm. And so, yeah, it sounds like you're a wealth of knowledge. I always tell people when I have people that are such a wealth of knowledge, I like to like soak in and see what I can learn.
We all learn from each
I
other.
know, exactly. So maybe can you tell us then, like, I think you probably mentioned this, like how all those experience shaped your approach to CNS practice and kind of what you do today.
Yeah, well, it did a lot to really delve into, the things. And as I was doing like in the CNS role, it's to help develop protocols, like I said, looking at the whole thing. And some that I'm, excited or proud of was like when the rapid response teams first came out. We were one of the first hospitals that had that, and just going to conferences and seeing what other people are doing and writing protocols and getting all that. And then even being on a team where we stratify, that's a CNS does, stratifies all the data and say, what could have we done to have prevented this? Initially, we were going to have a thing called failure to rescue. And I said, I don't like that name. We need to prevent a crisis, not failure to rescue. And so then we had twice a year classes for the nurses called Preventing a Crisis, and use case studies from our rapid response or even others to help what can we learn and how can we change our practice, or they may have just been interesting ones. So that's how kind of bringing the clinical expertise into and how a clinical nurse specialist does it. And like I said, with the clinical nurse specialist, you can do like the role that I've been describing in the hospital, but also in Illinois, because I am an advanced practice nurse, and the 4 specialties, the certified nurse midwife, the nurse anesthetist, the nurse practitioner, and the CNS all have our advanced practice license, which means I can prescribe. You have to get all your DEA and that. So I am currently, for almost the last 8 years, have switched over to work with the general cardiology group. And so I actually round on patients in the hospital, write orders, write notes, or I'll see patients in the clinic, or I help supervise stress tests. So that, there's different roles of how people use their CNS.
Right. Okay. Yeah. I know it's curious. I think because sometimes people confuse that with, CNPs and CNSs because it sounds similar, but you have your own, you still have your niche. It's not the same thing. It's a specialty area. And so CNS is your specialty area, even though, like you said, we all can prescribe as APRNs and you can round and do these things, but it's still a specialty area.
Yeah, it's a specialty in having that clinical expertise
in
that area. Yeah. Not that nurse practitioners don't, I don't mean that, but I mean, that's, well,
as
looking
CNS,
at the whole population versus just 1 or 2 patients or a group of patients. That would be the big difference, like a CNS, when I was in the hospital role, I would help write the heparin protocol for the acute coronary syndrome. In my role now, I prescribe the acute coronary heparin. I thought the others have no clue how hard it was to get that protocol and to educate the nurses so that they didn't make errors.
Yes. And so thank you so much for sharing your history and your, like your journey and like what you do, and especially the importance of, your specialty area as a CNS, as an APRN. You've been a member of ISAPN, so you were a CNS before, right? Before ISAPN. And so you've been a member for over 20 years. So what brought you to this organization then?
Well, it was so long ago, I don't remember. But I will say, so it was 96 when I became, the CNS, and then it was 2002 that I joined ISAPN. Okay. My guess is that another advanced practice nurse said, hey, come, or I got an email and we were doing a dinner meeting, and it was so exciting to be with other advanced practice nurses. I mean, that was the thing. I remember going and I thought, okay, they're mostly talking about their nurse practitioner, their family nurse practitioner, but that's okay. I get to be with these and learn,
Yes.
So, so that was, I honestly don't know. I think somebody just either I got an email or drugged me along. And I will say I thoroughly enjoyed when it was Region 3 at that time, before all COVID, where we had our dinner meetings. I mean, we just had a wonderful time and good collaboration.
Yeah. And that's really one of the important things too, is remember that no matter our specialty, because there's four of our, we have these four specialty areas as APRNs, but we're still APRNs all at the end of the day. And we can learn, as you said before, we can all learn from each other,
Mhm.
no matter what. It's so like, I love that collaboration and that, when I joined as a student, that same, oh, I get to be with my people. Like these are, like this is my
Yeah.
group of people. Like I'm gonna be here.
Yeah, yeah. Like I could pick their brains.
Yes.
Yeah. I thought maybe if I just sat by them, I'd learn something.
Yes. Especially when you're, a newer APRN too. You're
Yeah.
like, oh, I need to be like, just let me just be in the room with them so I can like absorb some of this knowledge.
Knowledge. Yeah.
And so now, as a CNS rep on the board, what inspired you to take on a leadership role in the organization at this point?
Well, a couple things. I will say, and we're going back in my career, back days, but like I said, I like to seize the opportunity before the opportunity presents. Well, I've been very active part of the American Association of Critical Care Nurses. My specialty,
Mhm.
for there. And so very active with them and know most of the national presidents and, just have done a lot with them. Well, I remember reading in one of their newsletters, they had a new test that was out, and it was the CCNS, so you could become a
Mhm.
certified clinical nurse specialist. So I thought, well, why not? But
Right.
it also said in there states that do not recognize it, and Illinois was one.
Wow.
And so I was like, well, that's sad. But I thought, I'm going to do it anyway.
Hmm.
So I did. And because, as I say, ISAPN pushed forward and put CNSs as an advanced practice nurse. In 2004, I got my advanced practice license because I had already had my CCNS, which is what I needed to get it in Illinois. So
Ah.
I have always been grateful for ISAPN because that gave me an advanced practice license.
Hmm.
And I tell people as they're going to school, where do you want to head even 20 years from now? And I think the master's degree in nursing education's good, but you don't get an advanced practice license,
Hmm. Right. Right.
versus the CNS.
Hmm.
So that's why I have a passion for ISAPN because I knew what they did for me. And then I had that CNS role, which it really didn't matter if I had an advanced practice license. But when it was time to switch to a different role, I had all the credentials to do it.
See, and that's definitely one of the things too that people has to realize is all the work that ISAPN has done for us before we even knew we needed something or we wanted something. Like they were putting in this work to make sure that we have all these, remove all these barriers that we have, and we still have barriers, but just where we've had so much success over the past few years, with just like getting some of the barriers to our practice so that we can, you know, work at the highest level of our licensure because that's what we should be doing.
Mhm. Well,
um,
and I put in a plug for the full practice authority.
mhm.
How hard I wasn't on the board, but I know that people had to work really hard to get that done because I've been in Illinois for a long time and
Mhm.
know we have a strong medical society,
Yeah. Mhm.
so I know that. And people were like, well, you can't use that at our hospital. I said, I know,
That's okay.
but I said, they were ISAPN worked hard to get it. I said, I'm going to get mine
The
just
least I can
because.
do, yes, the least I can do
Just
is just
because
get
I
my
could do
license.
it.
Yeah.
I don't know. As I retire, I may want it,
Mhm.
I don't know. So I've been pushing people to get that because we got to start
We have to
somewhere.
start somewhere, and the more of us that have it, the better it looks.
Hmm.
I People feel like, oh, I don't need it because I'm in a hospital system where they don't recognize it. But what happens tomorrow if you're not there anymore? And now the new position you're looking for is wants you to have full practice. Now you got to try to get a lot, like, so I say it's better to have it and not need it than to need it and not have it.
Have
Then
it.
you're trying to
Seize the opportunity.
Exactly.
Seize the opportunity. So I don't know where it'll lead me, if it'll help me at the end of my career or not, but I am part of that group.
Yes. We
I am
appreciate
part
you.
of that group.
With full practice authority. Yes, I love it.
Yeah.
And so
even though I went a whole year knowing, didn't know that I was supposed to put that after my initials.
oh, that's okay.
And I think you asked what prompted me to be the CNS on that.
Yeah.
Well, I will say that they ISAPN sent out an email that there wasn't anybody on the ballot and that the position would just be vacant. Well, you can see I'm passionate about the CNS role. I said, okay, what's involved? Sure, put my name on. And then I got voted in. So here I am. Sometimes I jump in and then figure out how to swim. So I jumped in and figured out how to swim. And I will say it's been a fantastic board. It's been great to be with April as the president. And it's just amazing to see all the background work.
Yeah, that gets done that people wouldn't know.
Yeah.
All the stuff that gets done behind the scenes.
Yeah.
Okay, so I think you've already told us about how the CNS position, how as a CNS, you're like the leaders and systems level change. I don't know if you don't think you touched on yet, like how does that translate into practice? Like how does that translate being that leader in practice? And maybe you mentioned that with, making sure you write the protocol and the nurses following it and there's no errors.
Right. And even just into clinical practice, cardiology has scientific guidelines. So when I was in my different role, I mean, I still look at them now, but I'd look at those and it was like, okay, how do we get this into our practice? And I distinctly remember, and this is going back, but talking about when we used to never give beta blockers to the MI patients. And sitting at a meeting and looking at data where that first came out to give beta blockers to MI patients, and you can see which cardiologists did and which didn't by their mortality rates. I said, I wish I had always kept that graph. I mean, it was just amazing. It was like, these work. And so then as a CNS and along with a team, figuring out how we make sure that every patient gets a beta blocker. And so we had even the MI core measures, the heart failure core measures, atrial fib core measures, and getting them down for nurses, to put so that they know before they discharge a patient that all these patients are on the correct medicines. Because as a practitioner, sometimes you might miss it or you need to document why they're not on it. And you might miss and a lot of times it was more documenting why they aren't on it.
Right.
But that way the next provider knew why they're not on it. They can't be on a beta blocker because their heart rate's 50, know.
Yeah, that
so did that answer that?
Yeah. Absolutely. And so as a board member for ISAPN, why do you think that CNS representation is important?
Well, we are one of the 4 specialties, so we need to have a voice. And I would love it if every hospital had CNSs for every specialty. I would say at the peak, you kind of go peaks and valleys and there. We were able to add a neuroclinical specialist, nurse specialist. We had an oncology one. We had a med surg, and we had a pulmonary and a cardiac. That was our department.
Oh, wow. All CNSs?
All CNSs. And then we had somebody that was really strong with geriatric and somebody with behavioral health and somebody with ortho that were clinical experts, but not CNSs. But that was probably our strongest time in the hospital and
Wow.
making things. And I remember, early on telling people that you needed to know what the ejection fraction was of your heart failure patient.
Mhm.
Now, it sounds kind of crazy now, but back then people didn't know. And they're like, we're not cardiac nurses, Cheryl. And I'm like, well, but I think you need to know. I said, it's just like not knowing what your blood sugar is on your diabetic patient.
Right.
Sometimes you got to put them in simple terms. And we went back and forth as CNSs, and it was like, okay. Even our CEO, when we went for our heart failure certification, he goes, I think I need to go find my number. He was like, what's this EF?
Wow.
Wow.
Yeah. So what would you say to a fellow CNS who wants to lead or advocate, but they're hesitating because they don't feel confident?
Uh, I would say you can always call me. I can kind of coach you through some of the things that I've done on that. But get over your lack of confidence because you are a clinical expert. You chose this field and, bring the data. Sometimes you sit at a meeting and everybody's like, well, what about this and that? Well, as the CNS, take that data, put it in graphs, make it meaningful, and say, this is where our problem is.
Mhm.
So show your value so
Mhm.
that people want to come to you to get things done.
And I tell people too, like, this information, you do this all the
Mhm.
time. Like I said, this is your expertise. It's
Mm-mm.
sometimes difficult for us to really own that and walk into that, but it's
Yeah.
already
And
in
I'm
you.
not saying I did everything right, that I had everything, but it is. And also, pushing when you got expert nurses, pushing them to do things to help you,
Hmm.
to push it forward. It doesn't need to
Exactly.
be just you, it's getting that whole team, but you bring that expertise because you have I say a little bit more time, not necessarily, you know, but you aren't dealing with discipline and things like that,
Mhm.
that you can
Mhm.
go look for the research out there and say,
Right.
this is why we need to do it.
Right. Exactly.
Yeah, putting that perspective on it.
Mhm. All right. And so, what are some ways that you think that CNSs can get involved, even if they're new grads, or even if they're not new grads, if they've been working and they're not involved in like a state level organization? What are some ways they can get involved?
Well, I think everybody needs to be involved. And I think, like I said, ISAPN, because there's so much behind the background that help us. So whether you want to be involved on committees, whatever, and if that doesn't interest you, at least become a member and know what's going on in your state. I would also say join a specialty. Like I went to critical care, American Association of Critical Care, and I networked with them. They were the ones that helped me. So if you're in neuro, if you're, be in your organization, you know, get out there so people know who you are.
Hmm. Yeah.
Make friends and network. And there's times some doctor gave me something and I was like, I don't know that we should do this. And I called up another cardiac CNS in Texas and I said, this is what we're trying to do. Is this safe? I mean, it was like you didn't have time to go look at all that, but I had her
Right.
number. I could call and we talk through it. And it was like, okay, we can do it, but this is what we need to
Mhm.
watch. I
Yes, and that's
needed,
the best. Just being able to call somebody, phone a friend, and say, "Hey, walk this through with me, or talk this through with me. Like, let me know your perspective." Like, yeah, that's like the
yeah.
best. That's why you never know who you're gonna meet where, so you have to get out and network.
Yeah.
Because yeah,
Network.
yes, network for sure.
Yeah.
Well, anything else you want to leave our listeners with today, Cheryl?
Well, like I said, just at the very beginning, seize opportunities, when they come, take them. Like this being on the ISAPN board, I just jumped in, but I'm really glad that I did. But other aspects too, the AACN, just very grateful that I did that. And, whatever certification you can get in your area, get certified, do what you can. And I've been very blessed in my career. God has blessed me from the very beginning,
Mhm.
there. So just very blessed in that and just really excited to see where we're headed with ISAPN.
Perfect. Well, I, for one, want to say thank you for putting your hat in and being on the board and the work that you've done over this last year since you've been on the board so far. So I'm just looking forward, like you said, as well to the future, to what's next for us. Um, so thank you so much for sharing your story, your passion, and I. I'm just like you. I love being a nurse. It's like one of the best things ever.
Yeah.
But you've shown us how powerful it is to lead with purpose and elevate the CNS role across Illinois. And so, for those of you listening, Cheryl's path reminds us that leadership comes in many forms. And whether you're a CNS, a CNP, a CRNA, or a CNM, your voice matters. So if you're not yet a member, as she said, we invite you to join us at isapn.org because advocacy is not optional. Advocacy starts with showing up, and together we can protect and advance the APRN practice in Illinois. So thanks for tuning in to Inside ISAPN. Until next time, stay informed, stay inspired, and keep leading forward.